Welcome to the Mountain West AETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to our medical director, Dr. Brian Wood, for the talk today.
I'm going to focus today on some presentations that I sat in on in the CROI conference related to HIV Hep C co-infection, and it was really intriguing this year. Whereas the last couple of years it was mostly about new Hep C drugs, there was very little about new drugs this year. There was a lot about epidemiology, there was a lot about who has Hep C infection, who isn't diagnosed, who isn't getting treated, and how we can improve the care cascade. And there was a lot of talk about eradication. I sat through 3 different talks that discussed Hep C eradication. And so I think that I say that just to show how the pendulum and the momentum is shifting in the field of Hep C towards discussions of eradicating hepatitis C infection. That just shows how far we've come. But with that, let me just talk about a couple of the abstracts that I found interesting. The first has to do with incidence of hepatitis C infection and reinfection among men who have sex with men with HIV in San Diego. The second is a study from France that looked at a mathematical modeling prediction of what's likely to happen with HIV Hep C in the next 10 years. And then I will just wrap up with what we learned about drug interactions with the new GP regimen for Hep C, which is one of the next we will see approved. But first, this study from investigators at UCSD that looked at the incidence of hepatitis C among men who have sex with men. I'll use the abbreviation MSM from 2000 to 2015. And as background, the way they presented the importance of this research is we know there are increasing reports of Hep C infection or acquisition among HIV-positive MSM, mostly from Europe and Australia. The data from the US, there's a couple studies, several of which haven't been published yet, but they're mostly smaller, and we just don't have really robust data from the US yet. So that was one of the goals. And they talked a lot about this systematic review that came out in 2015 that found an incidence, a pooled incidence of new Hep C infections in HIV-positive MSM of 0.5 per 100 person years, which I will abbreviate as PY. So 0.5 per 100 person years, certainly higher than among the general population, not as high as in injection drug users, but we'll sort of use that as our base of what was found in 2015, with the more alarming part of that report being rising incidence. So this group tried to use data from San Diego to determine both the incidence of primary Hep C infection or first Hep C infection among HIV-positive MSM, as well as Hep C reinfection incidence among those successfully treated. So this was a retrospective look at a large cohort of data from the Owen Clinic at UCSD, which is kind of San Diego's equivalent of the Madison Clinic. This is how they defined incidence of primary infection. So they looked at individuals. So again, these were all HIV-positive MSM. They looked at those who had a baseline negative Hep C antibody and then at least one follow-up test. And then for reinfection, they looked at those who had a 24-week SVR, sustained virologic response, generally thought to be synonymous with a Hep C cure sometime between these years, and then at least one follow-up test before 2016. And so really, they were just looking at this huge cohort of data of HIV-positive MSM and asking the question, okay, what is the rate of first infection and what is the rate of reinfection? These are the characteristics of the cohort. They had data for 2,400 individuals. The median age was 38. The ethnicity was mostly white or Caucasian. The median follow-up was 4.4 years. And here's the breakdown of drug use. And I communicated with the person who presented this afterwards just to clarify. So this was self-report. And so you can see here about a third reported no drug use. 42% reported meth only, meaning they use meth but not by injection. So this was meth but not by injection. This was injection drug use only, and then this was meth plus injection drug use, or about 20% were unknown. And I think that's one limitation of the study. This is self-report, and 20% they don't have drug use data for. But this is what they have by breakdown, and I'll show you the results, which are very interesting. So first, the overall incidence of Hep C infection in this cohort of HIV-positive men who have sex with men in San Diego was 1.185 per 100 person years. So remember that systematic review from 2015 was 0.5. So this is much higher than that. And then if we look at the incidence per risk group, so here's those who self-reported no drug use, meth only, so no injection, injection only, or meth plus IDU, we see here the number of infections, the person years of follow-up, and what I would say is there's very high follow-up and person years of follow-up for the no drug use group and the meth only group, much smaller follow-up, and I think this is also a limitation of the study. They had very few injection drug only users. Did I say that right? Okay, I think you know what I mean. But what you can see here is a much higher incidence than at baseline in those men who have sex with men who report using meth only. So this is men who have sex with men who report no injection drug use. So again, this is self-report, but presumably this is sexual risk or other risk behavior. You can see much higher than was reported in 2015 and much higher than the overall rate here. Not surprisingly, a very high rate in those who reported only using injection drugs, but limited by the low person years of follow-up. And you can see here a very wide 95% confidence interval, and not surprisingly, a higher rate than overall in those who reported meth and injection drug use. But I think the overall finding here is that HIV positive men who have sex with men who report meth use in the absence of injecting drugs do have a very high risk of hepatitis C infection. What I would say is they really tried to get at the reinfection rate, but again, their numbers were quite small. They only had 43 individuals with documented SVR, and those were all from the interferon-free era. They didn't have any data, and I don't know why, from the DAA era. And in this group, there were 3 reinfections. So you see here the reinfection rate, which also is certainly higher than in other risk groups and higher than the overall rate, but I would say these numbers are pretty small. So the other thing is if we compare this data to other cohorts in the US, you can see here there was this smaller group from Seattle. The biggest cohort with similar numbers was the MAX cohort, which was a few years ago. This was published in 2013. So I think the other thing we see here is that certainly if we go by these 2 big cohorts with over 2,000 individuals, higher rates than reported even just a couple years ago. And I think this is probably the most important graph and result of the study. We see here over time a rising rate of primary hepatitis C incidence in HIV positive men who have sex with men. This is overall. When they broke this down by drug use, this trend was similar for those who reported meth use only, no injection use. Also, for those who reported no drug use, it was on the rise. For those who reported meth and injection drug use, it sort of rose, and then there was a little bit of a downtick in the most recent era, and the investigators didn't really know if that was an anomaly or was a true reduction in that group. But so I think the take home here is that HIV positive men who have sex with men, if reporting meth use, are high risk for hep C, and we are seeing higher rates over time, even locally in the Western US. In terms of the reinfection incidence, again, I think they had some issues with small numbers, and I don't know that we can make a lot of this data from this cohort in San Diego. You see here a very wide confidence interval, but these are data from much larger cohorts from Europe, and I think that the general consensus is that reinfection rates also are higher. So the conclusion of this abstract was that we do know there are high and increasing hepatitis C infection rates in men who have sex with men who are HIV positive who report a history of either meth only, no injection drug use, or injection drug use. We do believe there's also an elevated hepatitis C reinfection risk, though I think the data from this study was limited. And the take-home point here being we need better behavioral risk reduction strategies for these risk groups and also routine screening. So I put this here just as a reminder of routine screening for HIV positive men who have sex with men who seem to have ongoing risk, whether it be condomless sex with multiple partners or injection drug use. So certainly everyone should get baseline testing for hepatitis C. Then what's in the primary care guidelines for those with ongoing risk is a yearly hepatitis C antibody test. What I would add to that, and I think the European guidelines are a little more detailed and better here, what I would add to that is every 3 to 6 month LFTs and repeat hepatitis C testing for any new AST or ALT elevation, or repeat testing 3 months after last injection drug use or last STI. So here what I've given you is kind of a composite of the US primary care guidelines and the European guidelines. And I think that gives kind of the most detailed protocol for screening high-risk HIV positive individuals, including high-risk MSM for hep C. And then the other thing I added here is if you think somebody's high risk, and especially if their AST and ALT are elevated, I would add a hepatitis C RNA to the hepatitis C antibody. Because again, as we've talked about, 5 to 10% of HIV-infected people might have hep C with a negative antibody, so-called seronegative hepatitis C. So just a reminder about screening. Again, the limitations of this study, I think lack of a detailed behavioral health history and self-report of drug use and small numbers in the injection drug use only group. And then their reinfection analysis, I think, was quite limited. Small number of reinfections only from the interferon era and a very small N in that group. So I think we need better data about the reinfection risk. But just a reminder that part of our counseling as part of gearing up for hepatitis C treatment is also discussing the risk of reinfection. And we have seen individuals get reinfected with hep C multiple times, whether it's from injection drug use or from sexual risk. So it is part of the counseling. Turning then to predictions for what's coming, and something I think optimistic and some very interesting data about what may happen in the all-oral DAA era over the next decade or so. So this is a mathematical model from France. All they did was they took hep C prevalence and incidence data from 2012 to 2016, along with predicted SVR rates for the available DAAs for these various risk groups, and they just predicted what's going to happen to hep C in France over the next 10 years. They divided it into risk groups, including injection drug users, MSM, who they divided into low risk and high risk, although I think one limitation of this is they didn't really give definitions. They didn't really explain how they defined that, and I didn't get a chance to ask them the question. Generally, high risk would be defined by condomless sex, especially with multiple partners, or meth or other drug use. So I'm assuming it was similar, and that's sort of how I would think about low risk versus high risk, but they didn't define that. And I'll just show you the data. So I think this is their prediction of what may happen in France over the next 10 years in the DAA era, starting with a baseline prevalence of hepatitis C. Again, this is in HIV positive MSM of about 5.5%. Here in the US, I think our baseline prevalence is higher, more like 15%, but within 10 years, even with 30% coverage, which means 30% people have access and get treated, they're looking at a decrease in the prevalence over the next decade all the way down to 0.55%, which is very dramatic. And then here they give you the predicted change in hep C prevalence. Again, this is limited to HIV positive MSM. If 50% of people could get covered and treated, 70% or 90%, and you can see here how these curves basically go down to the point where the remaining prevalence of hep C is only in those individuals who have not yet been diagnosed. So again, at CROI, there were multiple talks about eradication of hep C, both in this country. There's programs aimed at eradicating hep C in San Francisco, in Oklahoma, in other places, and in other countries. There was a lot of discussion using the term eradication. I think that just shows how far hep C treatment has come and where we might get to in the next 10 years. However, when the investigators broke it down between the predicted change in prevalence in low-risk MSM versus high-risk MSM, there was a difference. That difference being in high-risk MSM because of higher infection and reinfection rates if there's only 30% coverage, and they're using that term to mean only 30% have access and get treated. Actually, what's predicted is hep C prevalence rates will still continue to rise. So in order to decrease the prevalence in high-risk HIV-positive MSM, we actually need better coverage than that. They use 30% as a baseline because they estimate that's about the coverage right now in France. I tried to find a good estimate of what it is here, and the most recent care cascades I've seen is about 22% actually getting treated of those who have known diagnosed hep C infection. So I don't think we're quite even yet to this point here, especially for co-infected individuals. The take-home message here being that in the DAA era, if we can adequately get people access, get people treated, we actually have the potential to dramatically reduce the prevalence of hep C infection, including in co-infected individuals, potentially even eradicate the infection, but we need better access to the drugs, especially in high-risk groups. Then what they did is they broke this into, so here's just the graph from the previous slide. They broke this into chronic infections by treatment coverage, or they added what if we could treat people in the acute phase and get people treated and cured in the acute phase. And what they found is to make a dramatic reduction in the prevalence of Hep C infection for HIV positive MSM, we need both 50% coverage or access for chronic infection, and then also you can see here the incremental benefit of treating in the acute phase. I don't know anyone yet who is using DAAs to treat acute Hep C outside of a clinical trial, but it is being studied. So their conclusion and my take home from this is that now that we are in the oral DAA era, we do have the potential to drastically reduce the HCV prevalence even within the next decade, but we need improved access to treat chronic infection and ideally to treat acute infection. The investigators did bring up limitations of this study. It is a mathematical model, but what I would add is this was not the only abstract or discussion of Hep C eradication, and there were some other abstracts, including one from the Netherlands, that strongly supported this. In that abstract from the Netherlands, they just looked at the rate of new infection for Hep C from a couple years ago compared to now in the DAA era, and the rate of new infections had dropped by 50%. So I think we're also seeing very strong data that, like with HIV, we now know that treatment is prevention. We're learning the same thing about Hep C. Treatment and SVR and cure and getting that viral load to undetectable is a key part of preventing hepatitis C transmission as well. So Hep C, like with HIV, treatment is prevention and we need better access. So conclusions from this group of investigators is that what it will take to achieve Hep C eradication in HIV-infected persons is a few things. So one, behavioral risk reduction, counseling and reducing risk behavior, whether it be meth use, condomless sex, or injection drug use, regular screening, as we talked about, regular Hep C RNA testing in cured patients. I don't think we have great guidelines for how frequently to do that. Let's say someone has Hep C, they get treated, they get cured, and they have ongoing risk of reinfection. We don't have great guidance about how often to retest with RNA to see if they've been reinfected. So I think I would sort of use those same guidelines as for screening for first infection. They argue we need to maintain DAA treatment coverage at least 30%, ideally better. We need studies on Hep C transmission from HIV negative to positive persons because that wasn't included in their model, and we need to target undiagnosed patients for engagement in care. So then, in 2 minutes or so before we have time for questions and then turn to cases, I'll just turn to new drugs that are coming, in particular this combination, which I'm going to call GP, so I don't embarrass myself trying to pronounce it. So this regimen, I know John Scott has talked about in Hep C Echo. This is one of the coming things that is likely to be approved, I hear, sometime this summer. This slide is from John Scott. So this is an AbbVie drug. It's being called GP. It's a combination of these two direct-acting antivirals for Hep C. This drug, which is a pan-genotypic NS3-4A protease inhibitor, and this drug, which is a pan-genotypic NS5A inhibitor. The advantage of this combination being it seems, at least in some groups, to be fine to use only 8 weeks of therapy, so maybe that will allow for lower cost and better access. Also, it seems to be fine with advanced renal failure, so it may add access to those people with advanced renal disease, and it may have activity for individuals who have failed prior DAA therapy. It may have more activity against a Y93 mutation and other Hep C resistance mutations, though we need more data on that angle. Here I've just summarized some of the clinical trials to date, and I won't go through this in detail. We'll talk more about it once the drug is approved, but it has been studied in a number of different risk groups. For example, those with genotype 1 and no cirrhosis. Even co-infected individuals, 8 weeks of treatment worked really, really well, near 100% cure rates. In genotype 3 individuals, which is a very hard to treat genotype with no cirrhosis, 8 weeks also worked fine. In these other groups, like genotype 3 with prior treatment experience and cirrhosis, treatment was a little longer, like 12 weeks, but also worked very well. And then this trial of individuals with stage 4 or 5 kidney disease, it worked well and was safe. So it has been granted breakthrough approval designation by the FDA, and we do expect approval within the next 6 months or so, which is one of the reasons I bring it up. And I'll just end by saying that it seems really clean in terms of interactions with ARVs as well. We knew from a prior study that raltegravir or rilpivirine were fine, and that what we've learned here from this phase 1 study combining GP with either Triumec, abacavir 3-TC, dolutegravir, or Genvoya, ECF TAF, it really was fine. There were some minor changes in drug levels, but nothing that seemed clinically significant. And overall, the conclusion was no dose adjustment needed if GP is combined with ECF-TAF, which is Genvoya, or abacavir 3-TC dolutegravir, which is Triomec, and we also know it's fine with raltegravir or rilpivirine. So it seems like it will be a great option for our co-infected individuals as well. So my summary of these abstracts, and there were many more related to Hep C and co-infection epidemiology and eradication. We know that the risk of Hep C infection and reinfection is elevated in, I would say, HIV-positive MSM with certain risk factors like condomless sex with multiple partners, meth use, or injection drug use, and we need to remember regular screening in that group. Hepatitis C treatment is prevention and is part of prevention, just like HIV treatment is prevention, and we need better access and we need to get a higher number of patients treated so that we can have hope of eradicating the infection. And I think I've said that last one too. So I will wrap up there. Let's take a couple minutes for questions, comments before we go to cases. Anyone want to make a question or comment?